Welcome to the University of Toronto Joint Centre for Bioethics Seminar Series for the 2022 academic year. My name is Jennifer Gibson. I am the Director of the Joint Centre for Bioethics here at the University of Toronto, and it is my pleasure to be moderating today's seminar. Today's speaker is Professor Daryl Pullman. His presentation, as you can see on the screen, is "It's time to revisit the reasonably foreseeable natural death criterion for medical assistance in dying." The format of today's seminar is a presentation by Professor Pullman, followed by a moderated discussion with you, the audience. The seminar is being recorded and will be posted on the Joint Centre for Bioethics website, where you can also find other archived seminars. Before I introduce Professor Pullman, I wish to begin by acknowledging this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Now it is my pleasure to introduce today's speaker. Daryl Pullman is University Research Professor of Bioethics and Director of the Center for Bioethics in the Faculty of Medicine at Memorial University. In addition to his academic position, he has a clinical ethics appointment with the Provincial Health Ethics Network for Newfoundland and Labrador. Daryl has served on numerous national ethics oversight bodies, including the Canadian Institutes of Health Research Standing Committee on Ethics, the CIHR Stem Cell Oversight Committee, the Institutional Oversight Committee of the CIHR Institute of Genetics, and the Ethics Committee of the Royal College of Physicians and Surgeons of Canada. He was co-chair of the Ethical, Legal, and Social Issues (ELSI) Oversight Committee for the Canadian Longitudinal Study on Aging and has served on the advisory committee to the Canadian Public Health Officer. Daryl has broad and diverse research interests and has published widely on issues ranging from newborn screening to genetics, ethical concerns of bioarchaeology, ethics and aging, and end-of-life care. He is currently working on a book-length manuscript tentatively titled "Human Dignity and Bioethical Decision-Making." Welcome, Daryl. We look forward to your presentation.
Thank you, Jennifer. Am I on now? Okay. Great to be here. Happy to be the first of this year's seminar series. And without further ado, I'll just move right into it because I'm very concerned that I may have more material than time here. So I'm going to start by situating myself. I've been in bioethics now for pretty well 30 years. And when I first started in bioethics, David Roy, John Williams, and Bernard Dickens were among the leading luminaries in bioethics here in Canada. And they just published a ethics textbook back in the early 90s, in 1994, where they make this statement. They say, "It is not inconsistent to judge certain acts of hastening death to be ethically justifiable, or at least ethically tolerable, and yet simultaneously to maintain that laws should not be changed to grant doctors or anyone else advanced legal authorization to administer euthanasia." And and that is kind of the perspective that has informed my own thinking around ethics and end-of-life care and medical assistance in dying in particular. It's summed up as well in a paper that Grant Gillett, who's a bioethicist surgeon from New Zealand, he wrote a paper also in 1994 where he presented these two propositions. He said, killing a patient should remain against the law, yet this action may on occasion be the only right thing to do. And so in situating my own perspective, I would say that this kind of perspective has largely informed my own thinking around end-of-life care and medical assistance in dying over the years. All of us recognize that there are occasions, as the second statement says, those exceptional circumstances where it seems that actually ending a patient's life might be the only right thing to do. And yet, once we admit that, the idea of killing a patient should remain against the law seems much more difficult to defend. And so while we want to perhaps open the possibility that in very exceptional cases, we would want legally to permit physicians, or in our case here in Canada, nurse practitioners, to actually actively end a patient's life, we want to be very, very careful to ensure that those conditions are extremely limited, and that those are very exceptional kinds of cases that we would be considering when we take that approach. My perspective is this, that when any moral community grants some members the right or responsibility to intentionally terminate the lives of others, it must do so with the utmost caution, ensuring that stringent safeguards and oversight mechanisms are in place to limit opportunities for license and or abuse. To put it otherwise, we want to guard against the potential for double O doctors. That is, doctors who, though well-intentioned, now have a license to kill. And I say doctors here, and again, acknowledging that nurse practitioners also have that ability in Canada. And that, I don't think we want to lose sight of how momentous a responsibility that is, to actually to take somebody else's life into your own hands. And I think that's what the Supreme Court was thinking about when it made its deliberations that resulted in Bill C-14, that they were trying to be very careful to ensure that we were going to be very stringent in laying out conditions that were going to not open the door to license in this particular area, because effectively we as a society are giving some people a license to kill others, and we want to be sure that we're very careful in how we provide oversight and safeguards in that regard. So my objectives in the talk this afternoon are to review briefly the current state of MAiD in Canada, to examine some of the factors that have brought us to where we are today, and to discuss the need to review and revise the reasonable, foreseeable, natural death criterion for MAiD, because as you might expect from the title of my talk, I feel that we haven't done nearly enough to ensure that that safeguard is adequately in place in our current regime. So the current state of MAiD in Canada, of course, as you are probably aware, Health Canada releases an annual report each year outlining what from the previous year what the state of medical assistance in dying in Canada actually is, how many people applied, and so forth. And these are the numbers from the most recent report that just came out this summer. So in the year 2020, this is these are the numbers for 2021. We had over 12,000 requests. Almost all requests were actually approved, resulting in over 10,000 deaths due to medical assistance in dying. Of course, in Canada, you can either die, MAiD providers can either provide a lethal injection. I use the term lethal injection, but as you are probably aware, it's more a lethal infusion of a number of different drugs that will bring about the death of the patient. Or there's also the oral protocol, which would be where a physician or nurse practitioner would provide a prescription of a lethal cocktail of drugs that a patient would then be able to take and ingest on his or her own. So while that's an option in Canada, it's hardly ever used. Out of the 10,064 deaths that happened in 2021 in Canada, only 7 used the oral cocktail. So as a percentage of all deaths in Canada in 2021, 3.3% of the deaths were due to medical assistance in dying. Of the number of requests made, only 1.9% of them were actually withdrawn, although there was 13.1%. So if they list both numbers in the report, the 13.1% is the difference between the 12,288 or 12,165 that were approved and the number of deaths that actually occurred. Almost 11% of those actual deaths, or perhaps just over 11% of those actual deaths of the 12, the people died of natural causes before they actually received medical assistance in dying. Of those who did not die of natural causes but had still been approved, only 1.9% of those people actually withdrew or decided not to complete the process. Now, those are the raw numbers for 2021 in Canada. They don't, in order to, I didn't want to go forward to there yet. So in order to appreciate the what those numbers actually mean, I think it's important that we kind of put them into some perspective. So I want to look briefly now at the California End of Life Option Act, and because California also has legislation that permits physician-assisted death. In California, it's only physicians that are permitted to do this, not nurse practitioners. And interestingly, California's legislation came into effect in June of 2016. That's the same month and year that medical assistance in dying became legal in Canada. So California has a slightly larger population than Canada. It's about 2 million people more in California than we have in Canada. So it makes for a nice natural comparison of two liberal democracies, North American liberal democracies, that both have legislation in place to allow for medical assistance in dying or physician-assisted death. And so I wanted just to compare now the numbers from California to those in Canada. And here I use the numbers from both 2020 and 2021. And I highlight here in Canada in 2020, there were 7,595 deaths. In 2021, we had 10,000. In California, there were 435 deaths under their legislation. And in 2021, there were 486. That's quite a dramatic difference. Two countries or two jurisdictions that are largely have many similarities in terms of our sort of social political kind of perspectives and so forth. In fact, many might say that California and the US in general is a much more liberal kind of regime in many respects around some of the individual rights kinds of things. And yet in this particular area, Canada has a dramatically different result in terms of the number of deaths under the legislation. And I'll describe or spend some time talking about that shortly. Some of the other numbers I just wanted to point out, death by lethal injection, none of them in California were by lethal injection because it's just not allowed in the United States. In any jurisdiction in the US where physician-assisted death is permitted, there's the physician or medical provider is never the direct cause of death. They only use the oral protocol, which is significant, and I'll come back to the importance of that as we move on through the talk. And then I just wanted to highlight again the number of withdrawals and people, the percentage of people who did not actually complete it in Canada, 2.5 in 2020. I already mentioned the 1.9% in 2021. In California, it was 28.5% of people who had been approved for medical assistance in dying that did not actually follow through, and that number is even higher in 2022 or 2021, as it was 37%. And this again is quite consistent with jurisdictions across the United States. There's 10 different jurisdictions in the US, 10 different states, plus the District of, I can't remember if it's plus or including the District of Columbia, but in all those jurisdictions where they do permit physician-assisted dying, again, they only allow the oral protocol. And consistently over the years, Oregon being the first one that brought their legislation into place in the late 1990s. So they've had over 20 years of experience with it. They consistently, year over year, have around 30 to 35% of people that qualify for medical assistance in dying do not actually follow through with it. And the speculation seems to be that for many people who are concerned that their symptoms might be overwhelming at the end of life, they like to just knowing that they've got the option is sufficient for them. They don't actually end up following through. So those are all significant points that I think we want to keep in mind as we continue on with our discussion. So two quite different, my thing keeps jumping ahead on me here. So how did we get to where we are today? So I you know, we've seen the numbers. We see that Canada, in comparison to California, at least, we have a much more liberal regime in terms of medical assistance in dying. Many more people die in Canada due to medical assistance with the aid of a medical practitioner than happens in the regime like California. So how did we get to where we are today? Well, in shameless self-promotion, I would direct you to a paper I published a couple of years ago in the Canadian Journal of Bioethics, where the title of which is "In a Familiar Voice: The Dominant Role of Women in Shaping Canadian Policy, Medical Assistance in Dying." And while one aspect of that paper is to point out that the women's voice that we hear in the medical assistance in dying is not the different voice that Carol Gilligan talked about in her book In a Different Voice, talking about kind of a feminist perspective on bioethics. It's very much the familiar voice of individual rights and personal autonomy that feminist scholars have generally said is insufficient for describing it comprehensive social morality. Nevertheless, that's become the dominant voice in Canada. And in this paper, I kind of outline, going all the way back from the very first criminal code that came to effect in the late 1800s in Canada, that actually made not just assisted suicide, but suicide itself was to attempt suicide was considered a criminal act in the late 1800s in Canada. And how we got to the place today, I describe in this paper kind of the social evolution that's taken place that's brought us to where we are. So I think if you're interested in that detail, this would be a place to go. But I will just highlight some of the factors here. So this is the Supreme Court decision, the 2015 decision, which is now called the Carter decision, Carter versus Canada. Which itself is problematic, as I'll point out shortly. But this is the decision of the Supreme Court. If you recall, the case had originally been brought to the British Columbia, the Supreme Court of British Columbia, or the British Columbia Supreme Court, where it was Justice Smith who effectively said that the prohibition against physician-assisted death, as it was outlined in Section 241 of the Criminal Code, was unconstitutional. That was appealed eventually to the Supreme Court of Canada, and then the Supreme Court of Canada came down with its decision in which it sided with the British Columbia court, and that was the foundation for Bill C-14, which legalized medical assistance dying in Canada. So this is the Carter decision that we're talking about. But and here are a few excerpts from it, and I think it's very important to keep these in mind as we try to understand how we got to where we are today. So these are the Supreme Court justices. This is they point out, they say, even though it's called the Carter decision, they are very explicit. They say the impetus for this case arose in 2009 when Gloria Taylor. Now, if you look back at the previous slide here, you'll see that Gloria Taylor is the last plaintiff that's mentioned in this list of people. But the Supreme Court decided to focus effectively exclusively on Gloria Taylor's case. She was a person who was diagnosed with a fatal neurodegenerative disease, ALS, which causes progressive muscle weakness and so forth. And so that is the case that they are focusing on. And they say further on, they say, we agree with the trial judge being Justice Smith from the British Columbia Supreme Court, that an individual's response to a grievous and irremediable medical condition is a matter critical to their dignity and autonomy. And it says the law allows people in this situation, and again, it's in the situation of Gloria Taylor, somebody with a neurodegenerative disease or somebody with a terminal condition nearing the end of their life, they can request palliative sedation, refuse artificial nutrition and hydration, or request the removal of life-sustaining medical equipment. But the law, as it was then, prior to this decision denies them the right to request a physician's assistance in dying. And the Supreme Court in this judgment thought that that was just not right, that if you can request all of these other things, you should also be able to, that it's really removing support for your life. You should also be able to request the actual termination of your life. But they were talking about people like Gloria Taylor. When we think of some of the cases, and we'll take a look at them in a moment, some of the cases that we've seen in Canada where people who have chronic medical conditions, but they're not near the end of life, they've got many years of life ahead of them. Those people aren't asking for palliative sedation. They're not eligible to refuse artificial nutrition and hydration because they don't need artificial nutrition and hydration. They don't have to request the removal of life-sustaining medical equipment because they're not on it. So the rationale here that the Supreme Court is laying out doesn't apply to people who don't have a reasonably foreseeable natural death under any reasonable interpretation of what that might be. And we'll continue on with that as we move forward. And this is important to note as well, that even though it's called the Carter decision, the Supreme Court justices point out that Lee Carter and Hollis Johnson, those were the two individuals who took Kay Carter to Switzerland, where she received an assisted death. They're not focusing on that situation at all. They said this potential, they say they had an interest in their liberty, which could be engaged by the threat of criminal sanction for choosing to assist Kay Carter in her death in Switzerland, but they're not going to deal with that at all here. They're not dealing with the Carter situation, which again, as I say, is a very unfortunate that we now call it the Carter decision, because really the legal reasoning behind the Supreme Court deliberations had nothing to do with Kay Carter at all. And but that's become a central factor in the misinterpretation and the rapid expansion of the reasonable foreseeable natural death criterion ever since the law came into effect in 2016. And again, the Supreme Court just said the scope of this declaration is intended to respond to the factual circumstances in this case. And again, they're very clear. They don't say Gloria Taylor, I'm just adding that, but it's very clear from reading through the judgment that it's Gloria Taylor's case. We make no pronouncement on other situations where physician-assisted dying may be sought. And so I note that given this explicit statement, it's particularly disturbing that when the Truchon case came up in Quebec, and Justice Bedouin in Quebec said that she thought that the reasonable foreseeable natural death criterion was not acceptable, that it was a violation of charter rights, that the federal government decided not to take that back to the Supreme Court, because the Supreme Court was being very explicit that they were talking about a particular kind of case, and it should have been argued before the Supreme Court again if the RFND criteria was considered to be unacceptable, because the Supreme Court was very explicit in saying that this is for people who are at the end of their life, not for people who have a chronic illness that may cause them suffering for years down the road. But we'll come back to that again. As far as slippery slopes, and that's always the concern in any regime that's going to allow physician-assisted dying, is that there could be a slippery slope. Well, one of the individuals that testified before Justice Smith in the British Columbia Supreme Court situation was a professor from Belgium, and he suggested that based on what has happened in Belgium over the years, Professor Montero suggests that these cases demonstrate that a slippery slope is at work in Belgium. And in his view, once euthanasia is allowed, it becomes very difficult to maintain a strict interpretation of the statutory conditions. So basically, this individual was saying, you're going to have a slippery slope. It's very hard not to avoid that. But the trial judge, again, Justice Smith, and the Supreme Court of Canada agreed with her, the trial judge, after an exhaustive review of the evidence, rejected the argument that adoption of a regulatory regime would initiate a descent down a slippery slope into homicide. And they say we should not lightly assume that the regulatory regime will function defectively, nor should we assume that other criminal sanctions against the taking of lives will prove impotent against abuse. Well, we shouldn't assume it perhaps, but it seems to be, in my view at least, that it's actually the case that has happened here and is happening right now in Canada, which has resulted in the exorbitant numbers of deaths that we're seeing in terms of medical assistance in dying in Canada. So, so again, the Act, Bill C-14 came to effect in 2016. It lays out the criteria for medical assistance in dying, and I'm not going to go through all of them in the interest of time, but one of the criteria is that you have to have a grievous and irremediable medical condition, and it specifies this is what a grievous and irremediable medical condition is. It has to be serious and incurable, it has to have an advanced state of irreversible decline, it must cause enduring physical or psychological suffering, and the last one that we're focusing on here is the death must, their natural death has become reasonably foreseeable. So that's what the statement is, and so that is the criterion that's there. However, and this is just one of the cases. So that came into effect in 2016. One of the cases that was reported, and it's interesting. There every now and then cases like this pop up in the mainstream media, but they're never really followed up. There's never any hue and cry about it. That why isn't this problematic? You know, but this is an individual in British Columbia, a man suffering from depression. As far as we can tell, he didn't have any other underlying medical condition. So he's really has a mental health problem. Now, this is before, I mean, the criterion that's going to allow people suffering from a mental condition only won't come into effect until next year, even after Bill C-7. And yet we already have cases that have taken place in Canada where somebody suffering from a medical illness, which without any other specified underlying medical condition, have been euthanized in Canada, and that's only 3 years after the legislation came into effect, and yet there was no criminal proceedings. To my understanding, I think the British Columbia, the College of Physicians and Surgeons, looked at this and felt that this wasn't problematic. I think that's problematic, that we've got that kind of an approach to it. But then, of course, we've got the Quebec court striking down the restriction on medical assistance dying. So this is a report from the Globe and Mail, and I want you to focus on the highlighted sections here, because I think it again points to just the confusion and utter I mean, just lack of knowledge of what the law actually says, and which is reported continually in the mainstream news about this. So that this is a quotation from a Globe and Mail article. It says, the portion of the federal assisted dying law that Justice Bedouin, of course, Justice Bedouin, that is the Truchon case where Justice Bedouin said that it's unconstitutional to have somebody, that somebody needs to have a natural death to be reasonably foreseeable in order to be eligible for MAiD. So that was her decision. But it says the portion of the federal assisted dying law that Justice Bedouin signaled out as unconstitutional, a clause that required patients' natural death to be reasonably foreseeable, was championed by the Trudeau government, even though legal experts, now I'm not sure what these legal experts are, who they are talking about in particular, because clearly these legal experts never actually read the Supreme Court decision and their focus on Taylor. Even though legal experts warned it was out of step with the Supreme Court of Canada ruling, and it's not out of step at all with the Supreme Court of Canada ruling, and that paved the way for medical assistance dying. And then the earlier case was initiated by the 89-year-old Kay Carter. No, it was not. It was not initiated by Kay Carter at all. She's not even part of the discussion. even though, unfortunately, we call it the Carter decision. So it's just a lot of confusion here. So, so the Truchon or Bedouin decision really drives a wedge between suffering and dying. So sorry, I've got something popping up on my screen that I had to get rid of. Bill C-14 focuses on a single category of patients. It is a patient who is dying and experiencing suffering. So the reasonable, foreseeable, natural death criterion is a safeguard that was designed to pick out this class of patients. It's only this class of patients that are supposed to be eligible for medical assistance in dying under Bill C-14. The amended Bill C-7 expands this to two classes of patients. So now we've got either a patient who is dying and experiencing suffering, similar to to what was recognized under Bill C-14, but we also have or. It's not an and anymore; it's an or. You can either be that, or you can simply be a patient who is not dying but is experiencing suffering. And the reasonable, foreseeable natural death criterion applies only to the first set of patients. All right, so that's where we are now with Bill C-7. So as I said previously, this decision drives a wedge between suffering and dying. And once suffering is separated from dying and the justification for accessing MAiD, it makes it all the more important to assure adequate protections across the board, because now it's not people who are dying that are getting access to medical assistance in death. It's people who are simply suffering. And we're getting an increasingly broad interpretation of what that suffering might be. So we've effectively medicalized, we're in the process of medicalizing suicide in Canada, which is clearly beyond the scope specified by the Supreme Court of Canada in Taylor, or as it's called, Carter. And so again, it is disturbing that the federal government chose not to challenge this decision at the Supreme Court of Canada, because I really think we need to have the Supreme Court going back and looking at their rationale and deciding whether or not we want to be extending medical assistance in dying to just anybody who's suffering. Do we really want to medicalize suicide in Canada? Well, whether we want to or not, we're well on the way to doing that. And I find that particularly disturbing. So here's Bill C-7, that this is the amended act. And while that act was being discussed, there was some controversy because the Justice Minister, David Lametti, made some statements about what he saw the amendment in the act was intending to do. And his statement said, well, this is a quotation from that Toronto Star article. It says, some experts, again, we're not sure which experts they are, say they became alarmed when Justice Minister David Lametti, during opening debate on the bill last Wednesday, offered his view that reasonable foreseeability means a death that is expected in the relatively near term or over a relatively short period of time. A person's natural death is not reasonably foreseeable just because they are diagnosed with a condition that will eventually cause their death many years or decades into the future. Now, in my view, that's exactly what reasonably foreseeable should mean in a bill that is aimed at a reasonably foreseeable natural death. But there was a great hue and cry, and again, it seemed a great sort of much more political pressure, so that that the government seems to have backed off on that, even though the Justice Minister seemed to have a quite reasonable approach, in my view, to what reasonable foreseeability was. And in the same article, they quote Dr. Ellen Weeb. If you don't know who Dr. Weeb is, she's a physician from British Columbia. She's probably the most prolific MAiD provider in Canada. She's I think she has assisted well over 300, perhaps over 400 people, and my numbers could be low in that regard. She's very prolific. She spent, I think it's her full-time job is to provide medical assistance in dying. But for her part, Weeb said she is thrilled with the new bill, which she believes will make access to assisted dying easier for most people. She also said she considers Lametti's views irrelevant, and that they won't change her calculation that natural death up to 10 years down the road counts as reasonably foreseeable. And And here, Dr. Wiebe is fairly selective in which justice minister she's going to refer to. This was a quotation from an article, from a newspaper article published in March of 2020. But in September of 2018, she seemed quite willing to listen to the then Justice Minister Jody Wilson-Raybould. She said she had to go only on what Justice Wilson-Raybould's assertion that Kay Carter, the 89-year-old at the heart of the Supreme Court's landmark decision in 2015, again, that's just false, it's wrong, it's not right. But apparently Jody Wilson-Raybould said she thinks she would have been eligible for medical assistance in dying under the new law, which it's no doubt she wouldn't have been. The Supreme Court said they were making no decision about that particular case at all. They were interested only in the Gloria Taylor case. And yet this is the thinking that has infiltrated the medical community. It's infiltrated society in general. It's very much part of the very positive attitude that seems to have kind of this positive kind of fog that's overtaken our country, that everything is well in the medical assistance in dying realm. And the Supreme Court of Canada what is happening is exactly what the Supreme Court of Canada intended to happen. I would, as you can tell, I get quite vexed by all of that. So a brief summary of the amendments that are there in Bill C7. Reasonable foreseeable natural death is no longer required, but if you don't have an RFND, you then have a 90-day reflective period. You still need expert opinions there and so forth. There are potential safeguards in there to ensure that people that don't have a RFND still meet other criteria. And of course, beginning next year, if you have only mental illness as your sole diagnosis, you'll be eligible for MAiD as well. That is expected to come into effect in the spring of next year. So now we have two tracks for MAiD in Canada. We have track one, those are judged to have a reasonable foreseeable natural death, where you have an expedited process to receive MAiD, which generally happens in less than 2 weeks. And then there's track two now, those judged not to have a reasonable foreseeable natural death. And there's a 90-day reflecting period that's required. So you're basically, if you're judged to be eligible for MAiD, but you don't have an RFND, you're going to have to wait 90 days to receive MAiD. But now that this has happened, you might say, well, maybe now we should tighten up, and this is exactly what I'm saying. We should be tightening up the reasonably foreseeable natural death criterion, because 10 years, as Dr. Ellen Wiebe and people of her ilk, just does not seem to be a reasonably foreseeable natural death. But the Canadian Association of MAiD Assessors came out just this spring with this statement, and they said, we don't need to change anything about our reasonably foreseeable, how we've been interpreting it so far. There's no need to change the interpretation of natural death from that used prior to the legislative amendments. And they say that a person may meet the reasonably foreseeable criterion if they have demonstrated a clear and serious intent to take steps to make their natural death happen soon. So basically, if people are suicidal, or if they cause their death to be predictable. Examples might include a declaration that you're not going to take your antibiotic treatment anymore when you've got a current or future serious infection. You're going to stop. So it doesn't even mean that you have to have an infection right now. You might say, well, if I ever get this infection again, I'm not going to take my antibiotics. And according to this statement, hey, that would make you eligible for MAiD, and not just MAiD on track two. This would make you eligible on track one. if you decide to start taking oxygen therapy, to refuse turning, if you're quadriplegic, any of these things, so voluntarily cease eating and drinking, that would make you eligible for track 1, a medical assisted death. And again, it seems to me that is such a liberal and just wrong interpretation of what the courts intended, and is opening up the door again to medicalize suicide for pretty well anything. As it becomes just a very subjective kind of interpretation between a physician and the patient. And you can be shoehorned right back into reasonable, foreseeable natural death, even if your death is not reasonably foreseeable, and if the condition you're suffering from would not end your death or end your life for a number of years. So here are a couple of the other cases that have popped up in the news but never seem to get a lot of play. Ontario woman enduring the effects of long COVID begins process for medically assisted death. I'm not sure whether she's was going to be track 1 or track 2, but it seems that given the Canadian Association of MAiD assessors and providers, she could easily get into track 1 if she was judged to be track 2. In fact, there are some assessors that have suggested that people should just voluntarily stop eating and drinking, and if they're in track 2, and then they could be considered to be in track 1. So the Bill C7 doesn't seem to have changed things much, because people who didn't have a reasonably foreseeable natural death were dying from MAiD well before Bill C7, and now that Bill C7 has come into effect, people who are judged to be in track 2 can easily get shoehorned back into track 1, just because the Canadian Association of MAiD assessors and providers is willing to be very liberal in their interpretation of what a reasonably foreseeable natural death is, as they always have been. Here's a woman with chemical sensitivities chose medically assisted death after a failed bid to get better housing. This woman couldn't find a house that she could live in, and because she couldn't get other kind of social assistance to get into a place that she needed to live, she opted for MAiD and apparently received it. So when you talk about slippery slopes, I'll tell you folks, we're on one and we're going down fast. But far from being concerned about a potential slippery slope with regard to the rapid expansion of MAiD in Canada, the Canadian legislators and courts and other oversight bodies, including the various colleges of physicians across the country, seem intent on waxing the runners on the sled. We're not slowing down here, we're just picking up speed. So let's revisit the reasonably foreseeable natural death criterion. And again, going back to the California case, one of the things I wanted to point out is that that of these deaths here in Canada, these are the 2021 deaths. Of course, Bill C7 came into effect in March of 2027, but only 2.5% of these over 10,000 deaths were actually due to track 2. So even though we've got a legislative allowance now that you don't have to have a reasonably foreseeable natural death, the fact of the matter is that that very few patients are actually being put into that track. Now, of course, this it only came into effect in March of 2021, and given the 90-day waiting period, it could well be that we're only looking at 6 months worth of data here. And so we'll have to wait till next year to see whether or not we have many, many more people in track 2. But given the Canadian Association of MAiD assessors and providers tendency from the get-go to be very liberal and reasonable in interpreting what a RFND is, and given the fact that they seem to be intent on maintaining that, my suspicion is that unless we do something to tighten up what we mean by a reasonably foreseeable natural death very soon, many of the patients who would be judged normally to be track 2 and should have a 90-day waiting period, they'll get shoehorned back into track 1. That's been very consistently what the tendency has been with many of the MAiD assessors and providers over the first 6 years of our legislation. There's been this very liberal, open-ended policy, even when supposedly you needed to have an RFND. I don't expect that that's about to change. And in fact, the Canadian Association of MAiD Assessors and Providers says there's no need to change that. So, but now that we have these two different tracks, I'm suggesting that we need to start them up. And so I'm just about out of time here. So I'm just, here's a few of the lessons I think we can learn from south of the border. Although acknowledging that determining a precise time of death is an imprecise process, every jurisdiction in the US that prevents physician-assisted death requires that death must be expected within 6 months. Again, anybody that works in healthcare and works with end of life realize that it's very difficult to determine a 6-month time frame, and they recognize this in the US as well. But they still put it in there to ensure that we're not going to have people saying, well, 10 years would be a reasonable amount. That's just not reasonable. And so they put a 6-month requirement in. Certainly there would be people that would have lived perhaps 8 months, maybe 10 months, maybe a year, but they're not euthanizing people in the US that have many years of life ahead of them. So the Canadian application and recommendation based on that is that in light of Bill CS7 that extends MAiD to those who do not have an RFND, it is prudent to tighten the criterion to ensure that those eligible track 1 have an RFND on any reasonable interpretation. And I would suggest that Justice David Lametti's statements when they were first discussing this bill are very reasonable in that regard, even though many pro-MAiD people, pro-liberal MAiD people, I'm not anti-MAiD. I am very concerned about the pro attitudes that have just sort of taken over in Canada. But I think that we need a reasonable interpretation of what a reasonable foreseeable natural death is. Lesson 2, no US jurisdiction permits medical practitioners to be direct cause of death. Only the oral protocol is permitted. And as I pointed out, the 30% withdrawal non-completion rate indicates that the process itself serves as a natural safeguard for, and this is consistent. And if you read back on the annual reports that have come out of Oregon for over 20 years now, there are generally 30 to 35% of people who actually qualify for physician-assisted death who have received a prescription to get the medication, either never fail the prescription or having filled it, never take it. And it just seems to be that for many of them, simply knowing that they've got that as a backup is sufficient for them. And I would suggest that this might indicate a truly autonomous choice. So again, we've got those numbers there. So the lesson 2 for Canadian and application is that those eligible for track 2, that is those judged not to have an RFND on a clarified and reasonable interpretation of what that criterion would be, should be permitted only the oral protocol. I don't think we should have physicians or nurse practitioners being the direct cause of death. I think that for very vulnerable people, having a physician there or a medical provider who says, I'm here, I'm willing to do this for you, can be subtly coercive, even if the individual thinks that he or she isn't. So I would recommend that we only allow the oral protocol for track 2, and that we tighten up track 1 to ensure that only those that have really, under any reasonable interpretation, a reasonably foreseeable natural death would be eligible for track 1. So conclusion, failure to maintain the supposed safeguard provided by the RFND has resulted in the rapid expansion, slippery slope situation in which Canada now finds itself. And current interpretations and applications go well beyond what the Supreme Court of Canada contemplated in the Taylor decision. It's time to visit the RFND criterion with a view to ensuring that death is not only foreseeable, but that it is reasonably foreseeable as a result of natural processes. And I'm just going to conclude with this is a comment that a physician colleague of mine told me a while back when we were discussing these things. He says, anyone who has practiced medicine for a long enough will have encountered situations in which they did or didn't do something that they knew would result in a quicker death for the patient. However, those cases involved hours or perhaps days, not years. Somehow the latter just seems different. And I'd say it seems different because it is different. And we have to make sure that our laws recognize that and protect the vulnerable in those situations. So that's it for me. We still have 10 minutes left. So thank you very much. And I'm going to stop sharing.
Great. Thank you so much, Daryl. Really enjoyed your presentation. And I think you gave us a lot of food for thought, especially since we now are 5 years in with experience, actually longer than that now, with experience of medical assistance in dying in Canada. And there's always opportunities to reflect on where we started, where we're going, and where we might want to pause along the way. And you've given us some really good places to pause. It's now time for questions and discussion. And so I'm just going to reach out to the audience, viewers today. If you have a question, if you could just please put that into the YouTube chat box, and those will be communicated over to myself and to Professor Pullman. If you aren't logged into YouTube or alternatively, if you wish to ask a question anonymously, you can also send your question to jcb.ea@utoronto.ca. And that email address will be popped into the YouTube chat right now for those who may be participating on YouTube today. So Daryl, we already have questions coming in. And so here's the first one that someone has posed, actually quite a few. There's a question about, as you might recall, in 2017, there was an Ontario court ruling prior to Bill C-14 having been receiving royal assent that determined that the reasonably foreseeable natural death, what that means actually lies with the assessor and the medical community. And so that AB versus Ontario case seems to have suggested that, in fact, what we now see is that CAMMAP is filling that gap. It's providing that clarity around what it means for what reasonably foreseeable death may mean, and laying that on the shoulders of the assessor and the medical community. Could you comment on that?
Well, number one, I think you said that was before the bill received royal assent. Is that the case in 2017? I think the bill
was during a transition period. It was in 2017. It was during a period of time when Ontario did not have its own regime.
Yeah, and I think that's a very unfortunate decision, and I think that decision should have been appealed right back to the Supreme Court. CAMMAP is filling that gap, and CAMMAP generally has been very liberal, as you see from Dr. Ellen Weeb's statements, and she's quite influential in CAMMAP. She's and I mean, I talk to people in CAMMAP often, and I often hear, because the interpretation is, and I'm not even sure if the justice who made that interpretation in Ontario, because I'm pretty sure that when you look at Justice Bedelin's comments in her, you wonder if these Supreme or these provincial court justices have actually read the Supreme Court's decision. There's this very liberal interpretation of the Carter decision. I think that's really the spanner in the works, so to speak, is that we still call it the Carter decision, even though the Supreme Court said we're not dealing with the Carter situation at all. We're dealing with the Taylor situation, and the Taylor situation, as you know, was very similar to the Sue Rodriguez case that was argued back in the 1990s, and which the Supreme Court at that time, in a 5-4 decision, decided that they would not support her, even though they recognized that she had a legitimate claim. They said that there were too many unknowns around this, that to allow for that at that time, because they focused on Taylor in the when the Supreme Court made their ruling in 2015. They were able to look back at the Rodriguez decision and say, yes, the reasoning that we had there, we've now had another 20 years of experience. We don't think that the concerns that were raised there have been sustained. We think we can go forward, but they didn't say we can go forward the way we have, And I think there's just a short memory among the courts. And that these things need to be appealed all the way back to the Supreme Court, so that the Supreme Court can make rulings on them. There's too much confusion and just misunderstanding of the law there, even among so-called legal experts, that make these points. So yes, I agree that CAMAP has stepped in to do that. I think that's very unfortunate.
So thank you for your response, Daryl. There are 3 questions that circle around a similar observation, and a question for you about the proposal that around persons who having oral medication, the idea of oral administration for track 2, and the question about what does this mean for somebody who is unable to take medications orally. So I wonder if you might be able to comment on that, but it might actually exclude, by virtue of some of the limitations that a person may have in order to be able to self-administer. Yeah. As your
and again, there could be exceptional cases for sure. There could be somebody who's got a chronic medical condition that makes it impossible for them to do. I mean, we do have track 1. We do have the provision in Canada that you could, and there could be appeals in those kinds of situations. I think we'd have to have a very careful, it's one thing if you've got somebody who's got 2 weeks left to live, and you're saying that, and we've had some amendments because we say, well, people may not be conscious right at the time, and so we've recognized those things within the track 1 regime, the RFND regime, where we're talking about a really reasonable foreseeable death. Mm-hmm. I mean, I think we've got the provision there, and there could be appeals made on particular cases for sure. But I don't think, because we don't want to take the exception to set the rule. We don't want to say, yeah, there could be exceptional cases where there's somebody who doesn't have a reasonably foreseeable natural death under a tightened and reasonable criterion, who might not be able to administer this oral medication, and we could make provision for them. But we don't want to say, well, because we might have one of those cases, then we simply can't make that the requirement. As I said, they've been doing this for a long time in the U.S., and it's not that the Americans are opposed to litigation. We just haven't seen a lot of that kind of litigation being brought forward, and challenges in that regard. So
we're going to have to leave it there with those few questions, but there are some additional questions that did come up, and we'll make sure that you can have access to those to continue to sort of foster your own and thinking and reflection around this topic as well. So we'll make sure you get those to work with. And so I just want to, before we thank you for joining us today and inviting us again to really engage with this really complex and important topic within the Canadian story, I do have a couple of announcements I need to make. And so our next seminar will take place same time next week on Wednesday, on October 19th from 4 to 5 p.m. Eastern Standard Time. Our speaker will be Florence Ashley, who is an SJD candidate in the University of Toronto Faculty of Law, and was recently awarded with the 2022 Adele S. Cedra Distinguished Graduate Award. They will be speaking on the topic of the limits of criminalizing conversion practices. To sign up to receive our weekly seminar reminder emails, please email jcb.info@utoronto.ca, and this email address will also be put in the YouTube chat. And a gentle reminder to students enrolled in the CSB Interdisciplinary Seminar course to track your attendance at today's seminar. But Daryl, on behalf of all of us, thank you very much for your presentations and the insights and provocations you've shared with us today. Thank you.
Thank you. Thank you very much.